tonight we'll be going over Chapter 18, Neurologic Emergencies. All right, starting off with our National EMS Education Standard Competencies. For the medicine, it applies to the fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely ill patient. All right, some of the stuff we'll be going over tonight. Neurology. So we'll be going over the anatomy, presentations, and management of decreased level of responsiveness. When we start talking about altered mental status, we've talked about that a lot, right? Seizure, stroke. We'll also be talking about stroke and transient ischemic attack, or TIA. TIA. All right, again, seizures, status epilepticus, or epilepticus, sorry, epilepticus, and then also headache. All right, so intro. So stroke is the 5th leading cause of death and the leading cause of adult disability in the United States, according to the American Stroke Association. It's common in geriatric patients. Contributing factors for this, for stroke, include family history and race. All right, so there are some new treatments available for stroke that are coming out and that are already out. All right, so seizures and altered mental status may also occur when there is a disorder in the brain. So seizures may occur as a result of some of the following that you see here, such as recent or a prior head injury, brain tumors, metabolic problems, fever, genetic dispositions. You also have intoxication, head injuries, hypoxia, stroke. All right, there's some other things too. There's some other things too, such as when we start talking about fever, that can also cause issues, especially when we start talking about febrile seizures in our pediatric patients. Also, the treatments for these are going to vary widely, which you can see there's a whole lot of different reasons why that you can see, and there's a whole lot of different things that we can do for each one of these. All right, so the anatomy and physiology of what we got going on here. So the brain is the body's computer. All right, sometimes it's a little bit smarter than other times, but it is the brain's, or it is the body's computer. It controls the breathing, the speech, and all other body functions that we have. There are 3 major parts. You have the brain stem, you have the cerebellum, and you have the cerebrum. All right, so the cerebrum is going to be the largest part. All right, and you can see there's the cerebrum there. Right? Cerebellum, spinal cord. So a lot of things also happen when we start talking about seizures, altered mental status. If we have brain swelling, all right, if we have brain swelling, it's trying to make its way out of this area or any hole that's there. But for the most part, if it's a closed head injury, then it'll try and make its way through the bottom of the skull. In a hole, there's a large hole, or a foramen, called the magna foramen. So it's the largest hole that's at the bottom of the skull, where the spinal cord goes through, where the brainstem goes through. Okay. So what happens is, once the brain starts to swell, it tries to squeeze this part of the brain through. Well, in these areas is where breathing is, and where a lot of our functions, our core functions, are. And when it starts to get pressure, it starts to act a little hinky, right? Some other things that happen if it starts to swell up is that it puts pressure on the ocular nerve, and that's when we start talking about, you start seeing blown pupils, things like that, is when it starts to put pressure on that ocular nerve. All right, so the brainstem controls the most basic functions, such as your breathing, your blood pressure, your swallowing, pupil constriction. The cerebellum controls muscle and body coordination. The cerebrum, located above the cerebellum, that the largest area, right, is divided into two hemispheres, right and left. So each hemisphere controls controls activities on the opposite side of the body. So the front of the cerebrum controls emotion and thought. So when we talk about people that get lobotomies, or when we talk about the old procedure, the lobotomy procedures, that's what they do. They go through the nose or through the eye, and they would just try to mix up that part in there. They would try to destroy it, which would destroy a lot of the emotions and thought. So they would thought that that would calm somebody down, or there's a lot of things that they thought that treated. The middle part is what controls sensation and movement. And then the back part controls and processes sight. So in most people, speech is controlled on the left side of the brain, near the middle of the cerebellum. Or I'm sorry, take that back. It's near the middle of the cerebrum. The messages sent to and from the brain travel through nerves. All right. There are 12 cranial nerves that run directly from the brain to parts of the head. Right? So the rest of the nerves join in the spinal cord and exit the brain through a large opening in the base of the skull called the foramen magnum. All right. That's that large opening, that big foramen, the foramen magnum. So at each vertebra in the neck and in each vertebra in the neck and back, two nerves branch out from the spinal cord and carry signals to and from the spinal cord. All right, so if you look at this figure here on this slide, it illustrates the intersection of the skull and spinal cord. The spinal cord exits the skull at the foramen magnum, and two nerves branch out of the spinal cord at each vertebra in the neck and back. That's where you see that, right there. Goes all the way down, kind of looks like a horsetail down near the end. All right, this is also where if we start talking about dermatomes, all right, when we start talking about paralysis, why during paralysis, what part is probably the most likely to be injured at, where our injury is at. Okay, depending on if it's a paraplegic or a hemiplegic, or what have you, that's what we're looking for. Quadriplegic. So that's what we're looking for. What part of the spine is it injured at? At what area? All right, so pathophys. So there are many different disorders that can cause brain dysfunction, and it can affect the patient's level of consciousness, their speech, and voluntary muscle control. So the brain is most sensitive to changes in oxygen, glucose, and temperature levels. A significant change in any one of those levels will result in a neurological change as well. And we've known that because we've talked about it throughout. We've talked about oxygen, we've talked about glucose. Those are main things that the brain needs to survive, right? Those are what the brain eats, is that oxygen and glucose. They're very sensitive to it. If the brain doesn't get oxygen, what does it do? It tells the body to actually start changing functions of itself. It starts to get or your patients that have that hypoxia, they start experiencing hypoxia, then they get altered mental status. People that have hypoglycemia, they start to have altered mental status. People that have hypoglycemia, yep, they start to have altered mental status. And that's because it affects the brain. All right, headache. So, headaches, which I feel like I get all the time. So, headaches, it's one of the most common complaints that you'll hear from your patients in terms of pain is going to be a headache. So, headaches can be a symptom of another condition, or it can be a neurologic condition on its own. Only a small percentage of headaches are caused by a serious medical condition, only a small bit. So, tension headaches, migraines, and sinus headaches are the most common types of headaches. When we start talking about headaches, stress headaches, we start talking about tension headaches. These are going to be your most common types of headaches. So, your tension headaches, they're going to be caused by muscle contractions or muscle problems in the head and neck, and are also attributed to stress. So the pain is usually described as a squeezing or a dull, or it can be described as an ache as well, just a constant ache. So usually those type of headaches, they don't require medical attention. Now, if you start having those type of headaches long term, you may need to have your patient get looked at for that. Migraine headaches. So these are pretty serious for some people. I mean, ask anybody that's ever had a migraine. So they're thought to be caused by changes in blood vessel size at the base of the brain. All right. So the pain is usually described as a pounding, a throbbing, or a pulsating type pain. So when we talk about quality, can you describe to me your pain? And they start talking about their headache, then they could say it's a pounding, a throbbing, or a pulsating, and that would be a description, or that would be the quality of their pain. So it's often associated with nausea and vomiting, and may be preceded by visual warning signs such as flashing lights or partial vision loss for that, because there's pressure there. There could possibly be pressure there. So migraine headaches can last for several hours to days on end. That would be miserable. All right, sinus headaches. So sinus headaches are caused by pressure that is the result of fluid accumulation in the sinus cavities, right? Okay. So patients may also have a cold-like symptoms, some signs and symptoms that are like a cold, and a lot of them are nasal in nature. But they can also have that, that nasal congestion. They can have cough. They can have fever as well. So usually for this, pre-hospital care is not required for your sinus headaches. But the fluid buildup and everything can actually turn into that congestion, that sinus congestion. That can turn into something a little more serious if you get a pretty serious infection. All right, so serious conditions that include headache symptoms are going to be hemorrhagic stroke, so bleeding in the brain, right? Brain tumors, and then also meningitis. You have some others too, like when we talk about stroke. So stroke is what we would call a cerebrovascular accident, CVA. All right, in your documentation, that's how you'll put that in there, CVA, cerebral vascular accident. All right, so what that is, it's an interruption of blood flow to an area within the brain that results in the loss of brain function, brain functions. That's when we start talking about the fast, like we talk about fast facial, when we're doing a fast test on somebody. So we're talking about facial droop, we're talking about arm drift, we're talking about speech, so slurred speech, we're talking about how much time or how long ago, when was the last time they were seen normal. So fast, facial, arm, speech, time. That's some of the assessment pieces that we can use for our stroke scale. So ischemic stroke. So ischemic stroke is the most common. It accounts for about 87% of all strokes. So this results from a thrombosis. Remember what a thrombosis is, or an embolus, right? It's a clot that moves, right? A clot that moves, and then it gets stuck, and then it starts to, whatever's on the distal end of that clot or on the other side of that clot can't get blood. It can't get oxygenated blood to it, can't get nutrients to it, so it starts to die. And that's where we start to have issues. So the symptoms may range from nothing at all to complete paralysis in this, just depending on where that clot's at. Atherosclerosis in the blood vessels is often the cause of this. You remember atherosclerosis, what that is? You lose the elasticity in those blood vessels. Also, it creates that clotting function in there. And it clots up and can't, the plaque build up, can't get to it. All right, so there's an illustration that shows ischemic stroke. I'll get out of y'all's way so y'all can read that. So atherosclerosis can damage the wall of a cerebral artery, producing narrowing and or a blood clot when a vessel is narrowed or completely blocked. So the blood flow to the part of the brain may be blocked. And that's going to cause the cells to die because of the lack of adequate oxygenation. You can see here where the clot's at, right in this area. And because of that, everything downrange can't get oxygenated blood. And when that happens, this is what starts to die. And this is the stroke area. So if he's having a stroke, this is the back of the head. This is the occipital region of the head. If he's having a stroke on the right side of his body, which side of his body is going to show signs of stroke? The left side. That's right, this side. So you'll probably see some facial droop on this side, arm drift on this side. Good job. All right, hemorrhagic stroke. So a hemorrhagic stroke accounts for about 13% of strokes. This is the result from bleeding inside the brain. So anytime there's bleeding inside the brain, that is not good. A hemorrhagic stroke is bad. Blood is very bad for the brain as far as blood not being in the vessels doing what it's supposed to do. But blood on the brain is bad for the brain. It's very unhealthy for the brain. Cerebral hemorrhages are often fatal, very fatal because of those issues. People at high risk include those that experience stress or exertion. That's why it's very important to lead a stress-free life, right? And then why do we go to the gym? We're just exerting ourselves. We're leaving ourselves susceptible to have a stroke. All right. So we can talk after the next break. I'll get into Bell's palsy and what Bell's palsy is and everything like that. I'll see if I can find something pretty quick on it. If I can't, then I'll just talk about it. But I'm gonna try and pull something up on it. So when we talk about Bell's palsy, I'll talk about some of the stuff that you may see, some of the signs that you may see from Bell's palsy, and how it looks similar to a possible stroke patient. Thanks for bringing that up. As a matter of fact, so I don't forget, I will write that down. So I don't forget for our next break. All right, so Oh, absolutely. So yeah, so the Bell's palsy, you can get that at younger ages as well. Or it's a lot of times it's pretty common in younger aged people. All right, so people at the highest risk are going to be those who have very high blood pressure. So if you have blood pressure issues, that's why it's good to always make sure, because that blood pressure, remember, if you have high blood pressure, it's exerting too much pressure on those vessels and veins, which can create a weak area in those vessels and veins, right? And then they end up popping. You have an aneurysm or you have a stroke. Um, or if you have long-term elevated blood pressure that's not treated. Elevated blood pressure can be anywhere from 135 to 150 systolic. So actually 150 would be pretty high blood pressure. But if you're looking at 135 to 140, then you're elevated at that point, or you can be considered elevated. Just depends on what your normal is. So make sure you get that treated. Especially if you do get physicals at work. I know for our firemen, if it's found that you do have blood pressure problems and it's not treated, in some places, I know ours being one of them, we can't even let you come back to work until you seek treatment or you start to get treated for that. Just because we don't want to run the risk of you being on a call and you having a stroke. So we'd rather keep you safe and make sure that you take care of yourself. It's what's those physicals. It's very good that you treat those seriously whenever you have them. All right, Barry aneurysms. All right, so hemorrhagic stroke. Here's talking about aneurysms here. So Barry aneurysms are common cause of hemorrhagic stroke in our healthy young people. It presents as the worst headache of their lives a lot of times. Now, what this can cause is a subarachnoid hemorrhage. So the subarachnoid area, see if I got a nope. So let's go back to, I'm on 25 now, in this area. All right. And there you can see it there where they've pieced it out. So what happens is this vein, this vein was clicking on along, and then something caused it to get weak, this part of the vein to get weaker. And whenever it got weak, it bubbled out. All right. And that's what caused this. This is like a weak bubble here, an aneurysm here. And if that pops, then it's going to put blood all into this area, which is not good, right? Contact keeps moving around. All right, transient ischemic attack. All right, so TIA, which also on your when you're doing your documentation, if you're describing or if you're going to put transient ischemic attack, TIA suffices. So it's a stroke-like symptom that go away on their own in less than 24 hours. Now it's a warning. That's a warning for you. So it can be a warning sign of a larger stroke and is considered an emergency. Absolutely. So about 1/3 of the patients who have a TIA will experience a stroke soon after. So all patients with TIA should be evaluated by a physician. That is going to be what we would call a code gray. Send them in. Go to your, if you have a hospital that has neuro, that's where you want to send your stroke patients to. All right, so some signs and symptoms of stroke. So some signs and symptoms of stroke, generally, your signs and symptoms are facial droop, like we talked about, sudden weakness or numbness in the face, arms, leg, or one side of the body, decreased or absent movement and sensation on one side of the body, a lack of muscle coordination, what we would call ataxia, or a loss of balance. All right, so let's talk about that fast assessment. So when we're talking about a fast assessment, and I'll move my camera down a little bit, sit back. So we're talking about a fast assessment. What you're going to do is you're going to tell that patient, you're going to say, sir, ma'am, if you would, please close your eyes for me. Or what? I'm sorry. Let me back up. So I'm going to go ahead. I'm going to perform a fast assessment. What I'm going to tell my patient is, as I'm going to say, sir, ma'am, you do me a favor. Can you smile for me? And they'll smile. And if you see droop on either side of the face, okay. Also, you'll give them something to say, some sort of nursery rhyme or something like that. If you had, sometimes some companies have a piece of paper that they want you to read. And if they give you anything like word salad, words that don't make sense, nonsensical words, anything like that, if when they speak, they slur it, they slur their words, kind of like I'm doing now, almost sounds like, then that's going to be a sign also. And then what I do next is I generally say, all right, and I hold their hands up. I tell them to close their eyes. I tell them to hold their hands up. And I say, sir, ma'am, if you would, and I'm holding their hands the whole time as I'm talking. If you would, what I want you to do is I want you to keep both hands in front of you, and I want you to keep them up, all right? And then I let go of them. And if I see one start to drift, then I know that this is what the possible issue is, right? If this one's drifting, this is a possible issue, right? So I'm looking at that. What I also do is I have them, I can tell them squeeze my fingers, and I tell them squeeze my fingers as hard as you can, and they'll sit there and squeeze, and one of them will be obviously weak. All right, then from there, we talked about, so we covered facial, we covered arm, and then we covered speech. So what I do next is I ask somebody, or I'll ask somebody else or somebody that's been, hey, when was the last time this person was seen normal? And then they'll tell me, when what last time it was, because we're thinking of that. How long has it been going on? And also, are they going to be a candidate for some of the medications that they're going to get at that neuro facility? Okay. So fast. And I cannot spell today. I don't have my pen. That's terrible. All right. So some other signs and symptoms, sudden vision loss in one eye or blurred or double vision. Difficulty swallowing can be an issue. Decreased level of responsiveness, that's going to be an issue. Speech disorders, where we talked about the word salad, nonsensical speech, slurring. Aphasia, that's going to be the difficulty expressing thoughts. Like they know in their head what they want to say, but they won't be able to say it. So they'll be very scared, very confused. All right, expressive aphasia, that's what we talked about, the word salad. They can't use the right words, or if they have a difficulty understanding words, receptive aphasia. So word salad, known as expressive aphasia, and then difficulty understanding receptive aphasia. Makes right? Or makes sense, right? Then you have slurred speech, which is dysarthria or dysarthria. And then moving on, some other stuff that you can have is sudden and severe headaches, confusion, dizziness, weakness, combativeness, restlessness, tongue deviation, like the tongue will go off to the side, and then you can have coma as well. All right, so the left hemisphere. So the left hemisphere, a stroke in the left cerebral hemisphere may cause aphasia. All right, we talked about where speech comes from for most people. So that may be an issue for aphasia for speech. So aphasia, remember, is the inability to produce or understand speech. Speech problems can widely vary. And then strokes that affect the left side of the brain can also cause paralysis to the right side of the body, right? All right, right hemisphere. So strokes that affect the right side of the brain can cause paralysis of the left side of the body. Usually patients will understand language and be able to speak, but their words may be slurred and hard to understand. All right, so patients may be oblivious to their problem that they're having. Uh, so what this symptom is called is neglect. And then may neglect certain parts of their vision also. So it may neglect certain parts of the vision, may neglect and lack of pain cause many patients to delay seeking help. So that neglect of not knowing what's going on, which is and then also the lack of pain, then they may not seek help right away. Usually, a lot of times they'll see it in a mirror, or they'll just know something's not right because of arm grip, or they keep dropping something, or a family member or a friend or somebody like that will notice something. All right, so bleeding in the brain. So patients may have very high blood pressure. So it may be the cause of the bleeding. All right, that very high blood pressure. And it may be caused by the bleeding as a compensatory response. So a trend in increasing blood pressure is an important sign, it's an important sign as the body must increase the blood pressure to get blood to the brain's tissues. All right, so a lot of times with your stroke patients, they'll have this blood pressure that's just silly high, like 200 over something. And that's because it's trying to overcome. The brain's like, I need this oxygen now. I need it now. Blood pressure up. I need you to push this blood through, which can end up hurting itself in the long run. So a lot of times their blood pressure will be super high. So as that condition worsens, then the blood pressure may begin to fall, and it can fall pretty bad. So some symptoms or some conditions that may mimic a stroke, to include like the Bell's palsy stuff. So hypoglycemia may mimic a stroke. Postictal state after epilepsy can mimic a stroke, and then subdural or epidural bleeding can also mimic a stroke, because that's still the subdural. Even though it's not the blood isn't touching the brain. There's still blood inside of the cranial cavity that's causing pressure against the brain. It's putting pressure against it. All right, so this figure here, it shows intracranial bleeding, or bleeding inside the brain, or inside the cranial cavity. So most of this is caused by some sort of head trauma, and you can see the intracranial bleeding. All right, we'll take a break here in just a second. All right, seizures. So a seizure is a neurologic episode caused by a surge of electrical activity in the brain. In the United States, it's estimated that 3.5 million people have epilepsy. 3.5 million people. Seizures are classified into two basic groups. You have your generalized and your partial, or what we call focal seizures. Your generalized seizures are going to be like your tonic-clonic seizures. Two words, tonic-clonic. All right, so this results from abnormal electrical discharges from large areas of the brain, usually involving both hemispheres. So typically it's characterized by unconsciousness and a generalized severe twitching. the back and forth twitching a lot of times, and it may last several minutes or longer, which can be very dangerous. You also have what's called absence seizure, which does not involve any changes in motor activity. Is characterized by a brief lapse of consciousness in which the patient seems to stare or not respond. All right, they seem like they're off in la la land. They're staring straight. They're not responding when you're trying to talk to them. It'd be called an absent seizure. You have your partial or focal seizures. So a focal onset awareness seizure, there's no change in the patient's level of consciousness. You do have patients that may have a numbness or weakness or dizziness. They may also have visual changes or an unusual smell and taste as well. So you can also it can also cause some twitching or a brief paralysis in some of these patients. All right, so focal onset, it's an impaired awareness seizure, right? So the patient has an altered mental status and does not interact normally with his or her environment. This results from abnormal discharges from the temporal lobe of the brain, okay, the temporal lobe. Some other characteristics may be lip smacking, eye blinking, and isolated jerking. So patients may also experience, like we talked about, their unpleasant smells, also visual hallucinations. They may also exhibit uncontrollable fear, or they can perform repetitive physical behavior as well. All right, an aura, which can happen just before a seizure. So patients may experience a warning sign called an aura prior to a seizure. And it can include visual changes or hallucinations. People with a history of seizures recognize their auras and then can usually take steps to minimize the injury, such as sitting down or lying down before. Auras do not occur prior to every seizure, though, and not all patients with a seizure disorder experience auras. And this is something too when we talk about seizure dogs, or when we talk about some of our medical trained dogs, they get the feeling of that aura and they can come warn the owner. All right, let's go ahead and take a break right there. At generalized seizures, let's take a 10-minute break and then rock and roll on back. All right, 10 minutes, and I'll see y'all soon. All right. Let's rock and roll. All right, so our generalized seizures. All right, so they're characterized by a sudden loss of consciousness followed by chaotic muscle movement and tone, as well as apnea or no breathing, right? So it may exhibit bilateral muscle movement characterized by a cycle of muscle rigidity. So uh, a cycle of muscle rigidity and relaxation. We talk about that, the jerking movements, okay? Tonic, clonic. All right, so they typically last less than 5 minutes, followed by a postictal state. All right, your absent seizures. She used to have a grand mal seizure, which means grand mal, your full tonic clonic generalized seizures. And then they used to call absent seizures petit mal. All right, so small seizure, right? So an absent seizure, or what we used to call a petit mal seizure, may last for just seconds. So after which the patient fully then recovers. Only a brief lapse of memory of the event will be the issue there. Moving forward, you got status ellipticus. So seizures lasting more than 5 minutes, status ellipticus, because it just keeps going, right? So the seizures last more than 5 minutes and are likely to progress into status ellipticus after 5 minutes, right? So seizures that continue every few minutes without the person regaining consciousness or last longer than 30 minutes can be considered status ellipticus. So reoccurring or prolonged seizures should be considered immediately life-threatening situations. Remember we talked about there's no breathing going on. No breathing going on. So that's an issue. All right, and there's some of your causes for seizures there, which can be found in chapter 18, second table, 18-2. All right, epileptic seizures can usually be controlled with medications. Some of the medications that are used most often are right here. Most of these sound pretty common. Trade names: Keppra, Dilantin, Tegretol or Tegretol, Depakote, Topamax, and Klonopin. Those are pretty common. All right, so the importance of recognizing seizures. Can recognize a seizure. You can recognize when a seizure is occurring and whether this episode differs from previous ones. Very important for you to notice that. We also need to recognize the postictal state and complications of seizures. Most of the time, the postictal state, these patients are going to be out of it. They may have used the restroom on themselves, urinate on themselves or defecate on themselves. They're going to be very embarrassed because they're still trying to figure out what went on, or they know it went on. They're embarrassed about it because they know what happens. And then we need to identify the problems associated with seizures as well, or any type of underlying conditions that can be found after a seizure. Uh, that's maybe the only thing that rears its head early is that seizure. So when we start talking about brain tumors and things like that, that's a big, a young person that's never had seizures before, now all of a sudden having seizures, that can be an issue. All right, so the postictal state. So once a seizure has stopped, the patient's muscles relax and become almost flaccid or floppy, and the breathing becomes labored. It may be characterized by what we call hemiparesis, or weakness on one side of the body, and this resembles a stroke. So the postictal state is most commonly characterized by lethargy and confusion. If the patient's condition does not improve, you should consider other possible underlying conditions with that as well. All right, I see the syncope here. Let's move on. I'm going to bring up Christopher Mann posted this up here. I'll bring up this about since we just touched on like a stroke. See if I can bring this up. I'm going to share this out there real quick since he brought it up. All right, so this is from Penn Medicine. Some of the alternative names that you can see here: facial palsy, idiopathic peripheral facial palsy, cranial mononeuropathy, Bell palsy, and then you have Bell palsy. So it can affect most commonly ages over 65. It can also affect children younger than 10. I've seen a few kids with it, and I've seen a lot of adults with it. Males and females both affected. So it's thought to be swelling of the facial nerve or inflammation of the facial nerve in the area where it travels through the bones of the skull. The nerve and movement controls movement of the muscles of the face. So it's muscles of the face that's causing it to droop, not from a brain issue. It's a muscle issue. So some other conditions that may cause Bell's palsy: HIV/AIDS, Lyme disease, middle ear infections, sarcoidosis, so inflammation of the lymph nodes. So like when you get sick or anything like that, lungs, liver, eyes, skin, or other tissues. Having diabetes and being pregnant may increase the likelihood for Bell palsy as well. Some of the symptoms. So often start suddenly, but may take 2 to 3 days to show up. Difficulty closing one eye, difficulty eating, food falls out one side of the mouth, drooling, drooping of the face, such as an eyelid or a corner of the mouth, which would look a lot like facial droop, would be facial droop. Problem smiling, grimacing, or making facial expressions, much like you would see when you do your FAST exam. Twitching or weakness in the muscles of the face. You may also have dry eye, which may lead to sores and infections. I'm sure it could lead to some blurriness as well. Dry mouth, headaches, sense of taste loss, and then sound that's louder in one ear. All right, some things that can be tested for this is EMG, nerve conduction test, CT, and then MRI. Notice none of those we can do in the ambulance. So if you have this patient, it's always good to err on, you may be thinking that this could be it because they don't display all of the symptoms. The problem is that when we do the FAST exam, if you fail one piece of the FAST exam, we put you in the code gray area. All right, so a possible stroke patient, and then we send you to the hospital like a stroke patient. We want to do that just in case, and then let them decide whether it's Bell palsy or what. I don't want you to make that determination there on scene. I want you to suspect a possible stroke and take them to the hospital, get them to the hospital as quickly as possible, to the nearest neuro center as quickly as possible. So some things that are given: corticosteroids, medicines such as valcyclovir to fight virus. And then there's surgery to relieve pressure on the nerve. Let's see if we can we'll find some pictures of it. All right, so some of the pictures, so you can see how that can be mistaken, or it looks like a possible stroke, that facial paralysis. So we want to make sure that with this patient, I'm sending that patient to the hospital. There are some other things, dude. Those pertinent negatives are also, if they don't lack any type of arm drift, you would put that in there. You would put those pertinent negatives in there as well. And then also their blood pressure. If their blood pressure is normal, or normal-ish, then that could be a possible pertinent negative in there in your reporting. But we're still going to take them to the neuro center, and it still could be just as scary for those people as well. All right. All right. So Christopher Mann, he wrote, he had a friend who had it, took about 12 weeks to resolve from infection. It definitely looked like a stroke, but was such a gradual onset without any other symptoms. Still scary nonetheless, right? Because you never know until you can get your diagnosis. All right. Syncope. All right. What did we say syncope was? Besides the very obvious pointer right there. It's fainting, right? So syncope or fainting, that wasn't a laser. But your syncope or fainting, what we call fainting, in your documentation, we always call it syncope or syncopal episode. Or whenever you get that patient, you're going to say possible syncopal episode, or they're going to say had a syncopal episode, which means they fainted. All right, it's the reset, the body's reset. So seizures are often mistaken for fainting or this syncope. Syncope typically occurs while the patient is standing. So the seizures may occur in any position. So fainting is not associated with postictal state either. Fainting is fainting. All right, altered mental status. So altered mental status, aside from stroke and seizures, the most common type of neurologic emergency that you might encounter is going to be a patient with an altered mental status, or AMS. AMS. So some causes of AMS are going to include what you see here: your hypoglycemia, so hypo being low, and then glycemia, and that's going to be your sugar, right? Glucose issues in the blood, and then the emia in the blood. So low sugar in the blood, right? Hypoxemia, all right? Hypoxemia or hypoxemia. So that's going to be low oxygen in the blood. Then you have intoxication. We know what that is. Delirium, drug overdose, and unrecognized head injuries. All can cause this. Some more of this: brain infections, body temperature abnormalities, brain tumors, overdose or poisonings. A lot there. All right. So your patient assessment, let's just do a quick overview of a patient assessment here. So you're seeing size up, you're going to make an early determination whether the cause is a medical or a trauma. You're going to look for threats to safety and follow your standard precautions. PPE, is my scene safe, or BSI, is my scene safe? Right? You're going to ask that question. BSI, is my scene safe? And then your evaluator or what have you, you're looking around, seeing if it's safe. Or in the case of your assessment, your evaluator, you're going to ask them. BSI, show them, and then ask, is my scene safe? And they're going to say, blah, 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 yes or no. They're going to describe to you a scene, and you're going to have to say it's not safe yet, need to back out, or yes, it's safe, I can move in. All right, and we can continue on. So you're going to once you go through there, remember you got a few things: determine MOI, remember number of patients, and then you need to consider the need for spinal motion restrictions, so spinal immobilization. So if they've fallen or anything like that, possible head injuries, we may need to consider that spinal restriction. And then also make sure that we call for that additional resources. We call for them early. All right. So, hey, I'm going to get ALS on the way, or a technical rescue on the way, or a hazmat team on the way, or whatever you're needing as an additional resource. ALS will probably be the most common. All right, looking at your primary assessment, we're going to get that general impression, sick or not sick. Do I see any life threats right now? Do I see any life threats? Fix it. If we don't see any life threats right then, we have to bounce off into something else. Then that's where we start getting into that rapid exam. We're looking for their LOC, right? We're looking for that level of consciousness by going through our AVPU and seeing if they're alert and oriented. We're also going to review that chief complaint and then get that consent if we have the ability to get that consent. So some priorities that we're going to look at is your X ABCs, X being exsanguination, meaning heavy bleeding, major bleeding, exsanguination. And then you have airway, breathing, circulation. Circulation, we're talking about shock, things like that. Skin color, temperature, condition, looking for shock, stuff like that. All right, investigating that chief complaint. So in our history taking, if the patient is unresponsive, we're going to gather any history from family members or bystanders. If no one is around, we're going to look for explanations for the altered mental status. What's going on? We're looking for pill bottles. We're looking for, anything. You're looking for that, where did they possibly hit their head at, so on and so forth. So we may try to determine the events leading up to the incident, if we can do that, and then obtain a sample history. It says, on my thing, it says SMAPple on my notes. That's crazy. So we'll obtain that sample history, signs and symptoms, allergies, medications, past pertinent history, last oral intake, events leading up to. Hey, what's going on with you? Or what can you tell me what your symptoms you're having? Hey, do you take any, or do you have any allergies to any type of medications? Are you taking any medications or supplements? Do you have any past medical history that's related to what's going on right now? What was the last thing you ate or drank? And then what were you doing when this started? All right. Sample, right? Easy as pie. All right, from there, we're going to take our vital signs. So with these neuro patients, one of the vital signs we're going to look at taking also is that CBG. So be sure to add that in there as well if that's something that we may be thinking. If we're not seeing obvious signs of stroke or anything like that, that may be winner, chicken dinner, right? So the patients with significant intracranial bleeding, they may have a great deal of pressure in their skull that's compressing the brain. That can cause that AMS. So this slows the pulse and it causes respirations to be erratic at that point. Because remember, It's pushing it all towards that foramen magnum, right? Which is down near the bottom of the brainstem, which controls breathing, which controls pulse, all that good stuff, controls blood pressure. Blood pressure is usually going to be high to compensate for the poor perfusion in the brain. Remember we talked about? And then unequal pupil size and reactivity, also from pressure on that ocular nerve, that it can indicate significant bleeding and pressure on the brain, more of pressure on that ocular nerve. It blows those pupils out. All right, so our stroke assessment. You can see here the stroke scale evaluates the face, arms, and speech. So B-fast mnemonic or the fast mnemonic. You have also the Cincinnati pre-hospital stroke scale and the Los Angeles pre-hospital stroke screen are commonly used. Those get way further into the stroke assessment. You can look those up at any point. I encourage you to look them up, Google them, learn them, because it's really in depth. It gets really in depth, and it can really pinpoint on your strokes. You also have the three item stroke severity scale or LAG. You got your Los Angeles motor scale, which is going to be LAMS, and you got your Glasgow coma scale, which you should be given to every patient anyway. You need to start learning that right now. Your GCS, Glasgow coma scale. Start learning it. All right, so there's some of the stuff with the B-fast if you want to add the BE. So balance, sudden loss of balance or inability to walk. Is there a change in vision? So balance, eyes, and then facial droop, arm drift, speech, and time. Cincinnati, facial, arm, speech. Los Angeles, this one gets more in depth. You see you got full checkoff box there. These are all in your tables in your book. You got your lag, level of consciousness, arm drift, and gaze. All right, so all patients with an altered mental status should also have a Glasgow coma scale or a GCS score calculated. All patients with an altered mental status. I usually tell our EMTs all patients will have a GCS score put on them. So a lot of them, you'll come up, hey, GCS of 15. It just lets people know over the radio what you have. It tells that level of consciousness, and it gets a little bit more finite on the level of consciousness. It's a good thing to hear over the radio. All right, there's your GCS there. There are many ways to learn this. There's a lot of scenarios that we can go through to learn this, and I may start doing that now, is adding this in there, GCS levels. Matter of fact, during our next break, I think I'll work on that for our I think I'll work on GCS or put the GCS into our next patient assessment. All right, so from there, we're gonna do our reassessment. So on our reassessment, we're gonna focus on reassessing the ABCs. Remember, refocus on ABCs, vital signs, interventions, anything. We're gonna redo it, right? Looking for those life threats, checking those ABCs, rechecking those vital signs. Any interventions we gave, did we make it better or worse? How did it fare? How did that patient fare through it? We're going to compare the baseline findings with the updated information. What do we call that? When we compare multiple sets of reassessments or multiple assessments, what do we call that when we're comparing it? Does anybody remember?
Trending.
Trending, that's right. So we're going to start our trending process through there. All right, so we're going to watch carefully for any changes in the pulse, the blood pressure, the respirations, and any changes in that GCS score. We're going to give a GCS with every. Now we'll add that GCS to every scenario. So notify the receiving facility of the patient's chief complaint and your assessment findings from there. Any interventions that you did, and if there were any changes for those interventions after those interventions. All right, so your medical care, emergency medical care for these issues. So in most patients with a suspected stroke, physicians in the emergency department need to determine whether there's bleeding in the brain. So it's going to be more leaned on us getting them there. So if there's no bleeding in the brain, then the patient may be a candidate for a blood clot or a blood clot dissolving medication. Okay. So if bleeding is present, then the medication will increase bleeding with disastrous consequences, and we have to know that what's going on. So that's why we got to get them to the hospital so that as quickly as possible so they can make that determination. So we'll notify the hospital. What's very important, the last time the patient was known to be without the current signs and symptoms of a stroke. When was the last time they were seen normal? That's very important. So patients who have had a seizure, they require definitive evaluation and treatment in the hospital. Again, prompt treatment or prompt transport, right? So for patients who are having a seizure, we're going to make sure that we protect them from harm. We maintain a clear airway by suctioning. We provide oxygen as quickly as possible. And if a head or neck trauma is suspected, we're going to provide that spinal stabilization for those patients. All right, so for patients who continue to have a seizure or in status ellipticus, I get asked this a lot. We're going to make sure we suction the airway. We're going to provide positive pressure ventilations, and we're going to transport as quickly as possible to the hospital, as quickly and safely as possible to hospital, and we're going to rendezvous with ALS if that's possible as well. Because there are certain drugs that ALS can give. All right, for our headaches. So you should be concerned if a patient complains of a sudden onset severe headache. You should be concerned also if a sudden onset of headache with a fever, if they have seizures, altered mental status, or if it's following trauma. You should be concerned then with your headaches. For migraines, we always need to make sure we assess the patient for other signs and symptoms that could indicate a more serious condition. We want to make sure that if they can tolerate high flow oxygen, we're going to give high flow oxygen. And then also, if we can provide a darkened or a quiet environment, we're going to provide that as well. Don't use lights and sirens to transport those patients either. All right, so for your stroke patients. So we're going to support the ABCs and we're going to provide rapid transport to a stroke center. We're also going to maintain that SpO2 level of at least 94%. So that SpO2, keeping that up there, right? We're going to routine use of oxygen therapy is not recommended unless the patient is experiencing respiratory distress or is showing signs of hypoxia. Now, why do you think that is? Why do you think that? What does oxygen do to vessels? What does oxygen do to the smooth muscles? Okay. More so, the answer I'm looking for is constricts, right? Oxygen constricts those vessels. And if you already have an issue with blood flow, you don't want to have constriction on those vessels, right? So unless they're having some sort of hypoxia or marked hypoxia, we're just keeping them at 94%. At least maintain at least 94%. All right. So If they're having any type of respiratory distress or showing signs of hypoxia, go to 94%. Fibrinolytic therapy and methods to mechanically remove the blood clot may reserve stroke symptoms, or may reverse the stroke symptoms. And it can even stop the stroke if it's given within 3 hours for the drugs. So if they get the fibrinolytics within 3 hours, then it may stop the stroke symptoms. Or 6 hours for mechanical methods. Now you see why I'm saying that last normal time is very important. When was the last time they were seen normal? So if at all possible, we want to make sure we get them to a stroke center as well. So that's why it's always good to make sure you know who has neuro, or is your stroke center open, or who has neuro that day. All right. Your seizures. So the patient may be a postictal state by the time you arrive. Yeah, or an interventional cath lab. Mostly I'm looking for that neuro. But yeah, the interventional cath lab, because they're going to have to open that up anyway. If we're looking for neuro or we're sending a stroke patient there, they're going to have that. All right, so the patient may be in a postictal state for seizures. Once you get there, the patient may be having a seizure, quite possibly. So we want to make sure we keep that patient safe. We want to continue to assess the threats for XABCs, right? Exsanguination, airway, breathing, circulation. We're going to also, like we said, protect that patient from any type of harm. If the patient refuses transport after a seizure, we want to contact online med control and ask them to speak directly to the patient. All right. Always make sure you follow your local protocols to see what's going to be the best course of action for this. All right. Altered mental status. So we're going to determine the cause if we can. Provide that spinal motion restriction, airway, ventilatory support as it's indicated, and then we're going to transport to the appropriate facility. Easy stuff, right? All right, before we jump into this, let's take another 10-minute break, and then we'll jump into our practice patient assessment. Once we finish our practice patient assessment, then we'll move on to a couple of questions, or a couple of the review questions, and then we'll be closing out the lecture from there. So go ahead and take your 10-minute break, and then we'll come on back. Pull up my fancy schmancy clock here. Brought to you by Mac. Sorry, thanks. I was just sitting here thinking, I was like, what's the deal? Hey, so who wants to tackle this today? Who wants to come up and try their hand at this today? Sooner we get a volunteer, the sooner we get out of here, right? So who's gonna knock it out? Somebody that hasn't done it yet. Y'all gonna make me pick somebody. All right. Let's try doobie doobie doo. Just gonna run down here and pick out a random person. Who's it gonna be? Caitlin Baggett. Gonna rock and roll. Miss Baggett, would you like to rock? Let's do this today. Just open up your mic and we'll follow through. Mm. Ashley, can you hear me now?
Yeah, I can hear you.
Awesome. Ashley, I'm glad your mic works. You want to go ahead and knock this one out?
Sure.
Awesome. Sorry, that was a cruel joke. That was a cruel ploy. All right. And there's no doubt you're going to do just fine because we got everything right up here to help you. We're going to do the GCS today. So if you have your scenario sheet or if your patient assessment sheet, if you want to look at that, and then also if you have a little GCS scale, also we'll look at that as well. We can use that. All right, so here we go. So what we have is a 23-year-old female. She woke up and she's laying in bed. She appears to be confused and distressed. All right, go ahead.
Well, you're going to make sure your scene is safe. You're going to do your nature of illness and the MOI.
Oh, hold on. Slow down. You're doing good. You get way ahead. So all right. So you're driving down the road. What are some of the things you're thinking about? Some possibilities.
Scene safety, number of patients. Do I need additional resources? Stuff like that.
All right. So when we first pull up on scene, you're getting out of the truck. What are we always digging for in between the seats?
If
you've ever been on an ambulance.
No. Your AED? Your gloves?
Yep. Remember, BSI is my scene safe, right? Yep. BSI, and then the next question you want to ask your person that's doing your evaluation, you also want to take this, is my scene safe? And then I would say from there that you walk into the house and you don't see any immediate hazards and you're inside the patient's bedroom now. Okay, so the scene is safe. All right, go ahead.
So you would do your OMI and your NOI, nature of illness?
Yep. All right. So judging from what you saw is that the patient's sitting there, she's kind of rubbing on her head, so possible headache, and then she's laying in the bed. So we're not really thinking anything traumatic, right? She's laying in the bed at this point. But she's very confused. She's kind of confused. So what do we call that when somebody's confused or they're not acting right?
Disoriented.
Or altered mental status, right? AMS.
Yep.
All right, awesome. All right, we only have one patient. All right, so what would you like to do next? So we're at number of patients. So what would you like to do next?
Oh boy, tonight. I guess is like her LOC.
Nope. Remember the additional resources. Just go right down the line. Right down the line. So we're at number of patients, and then we're going to request the additional EMS assistance, right?
Yep.
So considering what this nature of illness is, who are you gonna call? Do you need ALS backup for this?
Probably not, no.
For an altered mental status?
Then yes.
Yep. So for an altered mental status, I'd go ahead and call them because we don't know what's going on yet. Always call, right? It's all
Yep.
if you want to be on the safe side 100% of the time, you can call. Hey, I'm gonna have ALS en route. Easy as pie, right? You knock that one out, you ain't even gotta worry about it. All right, so she's laying in the bed. What would be next? So after additional resources, what would be the next thing?
Probably your initial assessment.
Right, so we're gonna consider stabilization of the spine. All right, so your initial assessment's next. All right, so going with our primary survey now and resuscitation. So what's the very first thing in our primary survey we're looking for? That general what?
The level of consciousness.
So that general impression, right?
Mm-hmm.
Okay. So here, let me pull this up too. This will probably help you out too. There we go. All right, so your general impression. So you've seen the girl, the 23-year-old female. She's laying in the bed. She appears confused and in distress. So would you say this patient is sick or not sick?
Sick.
Sick. That's right. So your general impression, this patient is sick because she's laying in the bed, appears confused and in distress. All right. So now we're gonna get into that level of consciousness you've been itching to get into, right?
Yeah.
So level of consciousness, you come walking up to her, she's not really paying attention where you're at because she's confused. But then you come walking up to her and you say what?
What's your name?
Yep. Hi, my name is, just introduce yourself, right?
Yeah.
All right. So you would introduce yourself. What's your name? And the person, she looks at you at that point, but she's still kind of disoriented. So she did look at you when you talked to her. So on the AVPU scale, what do we put that as on AVPU? Alert, verbal, painful, or unconscious or unresponsive?
Alert.
Nope. So if she watched you come in the room, that would be alert. But if you had to talk to her to get her attention or anything like that for her to respond to your verbal, that would be verbal, right?
Mm-hmm.
All right. Great, great. All right. So from there, we're going to introduce yourself. We're going to determine a chief complaint. So her chief complaint is severe headache, blurred vision, and an altered mental status. Okay. You don't see any apparent life threats as of yet. You don't see any apparent life threats, but we're going to go through anyway, step by step. So after you determine chief complaint or you see any life threats, you don't see any, what's the first thing we get into?
Her airway.
Yep. Okay. So what do you want to assess with her airway?
Her breathing.
Okay. And in order for her to breathe, she has to have what?
Full oxygen.
Well, remember, if my mouth is closed or if anything's in it, I can't breathe, right? So in order for me to breathe, I got to have a patent airway, right? So I'm going to assess and see that her airway is patent. And if I'm listening for breath sounds, I'm listening for her breath sounds to be what? What do they need to sound like?
Clear and like no like wheezing or
Okay.
stuff like that. Like
Okay. Okay. So we're looking for clear breath sounds. We're also making sure that it's bilateral, right? So you listen to her breath sounds. She's got an open airway. Her breath sounds are clear and bilateral on both sides. And then you assess her ventilation. So her ventilation, which is the actual mechanical part of her breathing, is regular and unlabored. So at this point, what would you want to do?
I would probably want to check her circulation,
Okay.
like her pulse and her temperature.
Okay. So there's no active bleeding at this time. Her pulse is regular and strong, and her skin is warm and pink.
Okay.
Okay. So do you want to at this point give her any interventions? She is confused. She's distressed. And what is something we can give a patient that may help with distress?
Oxygen?
Yep, you can give oxygen. Now for an AMS patient, what am I gonna? I'm gonna go ahead and try to slap a vital on, get a quick vital on something real quick. What am I gonna try and look for?
Her BP?
Okay, or what's another one for oxygen? If I'm looking
Uh,
at oxygen,
her
just
O2?
yep, her O2 status, her initials 98. But that oxygen does give some properties of it helps distress. So I'm going to go ahead and put her on a nasal cannula since this does tend to help. A nasal cannula at um, at 2 LPM at 2 liters per minute. So I'll put her on a nasal cannula, low flow oxygen. That's all I would put her on. All right. So at this point, you finish that up. Now we're at transportation, right? You did A, B, C. Now we're at transport. How would you see this patient? How do you think they need to transport? Remember,
Um,
all AMS patients. She's a
a
altered mental
priority?
status patient. Yep, she's a high priority. Need to transport immediately with ALS support, right?
Yes.
Awesome. So your 15 minutes is up at that point. So you're out of that danger zone there when you're in your skills assessment. So your 15 minutes is up just in that little bit there. Now we can kind of take the breather. We can start to get more of the assessment done, and we move into our history taking.
Okay.
All right. So for history taking, what are we looking for?
Uh, her last input and output, like last drink or last meal,
Okay.
any medications that she could have taken.
Okay. All right. So we want to. What do we call those? What are the mnemonics for those? Remember, she's
Um,
got a headache too, so she does have a pain. And since she has a pain, we're going to do OPQRST, right?
yes.
That's the first mnemonic, and then the second mnemonic, which you were hitting on, is what do we call that mnemonic? What's the abbreviation we're doing on that one?
Um, my mind is everywhere tonight.
Do you have your screen on? Are
I
you
do.
able to?
I do. The sample.
Yeah, there you go. Um, so if you get caught up, just look at your screen there. I'm gonna keep up with it, okay? All right, so when you're doing OPQRST and sample, how do you ask those questions? Let's start with O, onset. How do you ask that?
When did this occur or when did this start?
So it started suddenly about 10 minutes ago. Okay, next question.
Um, does P mean like the past?
Oh, provocation. So provoke, does anything make it better or worse? So when you say, does anything make it better or worse? I could say, no, I was just reading when it started. So no, nothing makes it better or worse. All right, what's the next question? Q.
Quality.
Okay, and how do we ask that question?
Is there anything that helps it?
No, that would be provocation. So quality would be, can you describe to me your pain?
Okay.
Yep, can you describe to me your pain? And I would say, well, it feels like the worst headache of my life. All right, and then next is radiation. So how do I ask that question?
Where does it hurt? Like where does it start or where does it hurt more than the other?
Okay, yep, you can say that. Where does it hurt exactly? And does it radiate? Does it move anywhere? Does it radiate anywhere? And I'm gonna tell you no. All right,
Okay.
and then next is severity. what is the fun question we always ask for severity?
1 being the least and 10 being the worst. What is your pain level?
10 out of 10.
Wow, you're
10 out of 10. Okay. And then for time, how do we ask that question?
when did this start?
Yep. So it's been pretty consistent since it started about 10 minutes ago.
Okay.
All right. So then if we're doing any type of clarification questions, some things that you can ask, just think about this in your head. Is there any numbness or weakness? That would be a good thing to ask for your neuro patients that are having this type of pain and everything. Are you experiencing any numbness or weakness? And then I would tell you no, just the headache and blurred vision. Okay. And then we're getting into sample history, right? So how do I go about asking those sample questions?
What is the chief complaint?
Okay, so and sample hey, can you tell me what your symptoms are, your chief complaint again, or what have you? Then I'm gonna tell you I just have a headache and the blurred vision. Okay, and then
Um,
my wife is doing something out in the living room. She's making really loud noises. I don't know what she's doing. Sounds like she's trying to annoy my 10-year-old. So it's distracting. All right, so next, after signs and symptoms, we have what?
allergies.
Allergies, and how would you ask that question?
Is there any allergies or anything that you could be allergic to?
No, I don't have any known allergies. Okay, next question.
Would be medication.
I take birth control pills currently. Remember, I'm a 23-year-old female.
Okay. And there would be your past medical history. Have you had this before? Do you have any underlying health conditions that this could?
No, I don't have any previous similar episodes to this.
Next would be your last oral intake. What did you last eat? What did you last drink?
I had dinner, roast beef and sweet tea about 2 hours ago.
And the last one would be events. What were you doing when this started, or what happened? That could
I
be.
I was reading in my bed.
Okay.
Okay, so now you're done with that. You're done with your history taking. If you wrote that down, because we'll be talking about it later, right?
Mm-hmm.
So secondary assessment. All right, so for this, hold on, let me flip this. All right, so if you're looking at your slide, so would you consider this, do we need to do a detailed or a focused assessment? Do you think it'd be necessary to do a detailed head to toe,
No,
or do
I
you
think
think
it'd
we
be
need to do a focused?
a
Okay.
focus assessment.
All right, and what do we want to focus on?
Her headache to
Right,
make
right. The neurological, right?
yeah, yeah.
Yeah, neuro. So, in looking at neuro, we know that her some of the things we're going to look at is that altered mental status. We recognize that she has a severe headache. You just said that, the blurred vision, and then what with neuro? What else am I going to look at with neuro?
Her LOC,
Okay, that's her AMS, right? Her altered mental status.
her eyes, her pupils.
Yeah. Yep. Pupils. That's right. So I'm looking at her pupils. They're equal and reactive to light. Okay. So we go from there, and I always look at some of the other stuff too, just in case. So I hit the focused one first that I'm looking for, and then from there I'm going to go with cardiovascular. She's got a regular pulse. We already know that. She's normal blood pressure. Integumentary or skin check. We check that. It's warm, pink, and dry. Pulmonary. She's got clear breath sounds. Musculoskeletal. We're not having any issues with trauma, so there's no deformities or injuries noted. GI or GU, there's no complaints. And then psychological or social, she's anxious, right? She's under distress, she's anxious. All right, so after we do that focused assessment, we cross into the next piece, which is vital signs. So what do we want to check? What is what is something you want to check for vital signs?
Her blood pressure,
Okay, her blood pressure is 130 over 85. What else?
heart rate,
Heart rate is 75 and regular.
and her oxygen.
Her her oxygen is 98%. Her respiratory rate is 16 and regular. She's 98% with 2 liters. All right. What else may we want to check? Remember altered mental status? What else might we want to check too?
Her LOC and maybe her pupils again.
Nope. You could, but you check those. But with their altered mental status, you don't know what it may be. A little bit of blurred vision there. Possibly she's confused, anxious. Something else we could check would be what?
Her O2.
CBG, right?
Yep.
So we could check it for a CBG if you wanted to, just to be on the safe side for your AMS patients. And CBG would be we would just go ahead and say that her CBG is 100, which is good, All right, so at this point, so at this point, what would you think that what would be your impression of this patient? What would be your field impression for this patient?
Well, considering she has no injuries, but she's disoriented and she has a severe headache, maybe a possible concussion?
Okay, no, a concussion, she wouldn't have that because no trauma, right? She's been laying in the bed. So it just started happening all of a sudden. Severe headache, problems. So we're thinking neuro. So since we're thinking neuro, we're thinking brain. So what type of event may be going on?
Um,
Remember we talked about some things that could cause that sudden severe headache?
an aneurysm? But
Hey, awesome. Awesome. Good one. All right, so we're thinking of some possible cerebral vascular event or an aneurysm. We'd be thinking that's a possibility. Okay, so thinking that's a possibility. What are your interventions? You want to make sure you verbalize these. So you would maintain her airway, continue her oxygen. Uh, you would keep her in a comfortable position and prepare for rapid transport with continuous monitoring.
okay.
Yep. Her glucose was good. Her glucose was 100. All right. So after you did the oxygen, you maintained the airway. It's been 5 minutes. You got her on rapid transport going. It's been 5 minutes. What do you want to do?
Repeat vital signs again.
Awesome. So you repeated the vital signs. And what were her vital signs the first time? Do you have that?
180 over 95 for her BP and 75 in regular for her heart.
Nope,
And
130.
6.
Hold on,
Oh,
130 over 85 for her BP. 130 over 85.
oh, my bad.
That's it. That's right. So 130 over 85, 75, 16 in regular for respirations, 98% on 2 liters. Cool. All right. So now, since you did all the awesome interventions and everything, then her blood pressure is 125 over 80. Her pulse is 70. Respirations are 15. SpO2 is now 99 because she's been on O2. Okay. So you want to reassess those vitals. You also want to reassess that neurologic status, right? And you want to recheck her OPQRST, or you want to check her severity of her headache, quality and severity of the headache. See if it's moved anywhere. Okay, so you did all that. The headache still hurts. Not a whole lot we can do about that. We got her on a little bit of O2 just to keep her calmed down, just a little bit. All right, so you showed up to the hospital, and Nurse Karen comes up and says, "All right, what you got?"
I have a 23-year-old female. And upon the chief complaint, when I arrived, assessed she's had no injury or trauma. She said she was just reading a book. She had a severe headache. Her first set of vitals were 130 over 5, over 85. Her heart rate at the time was 75 and 16 for her respirations, and we gave some oxygen to help calm her down, and she was at 98 for um, the 2 liters at the time. She said that the only medication she took was her birth control. Nothing prior was leading up to the event, and her last set of vitals were 125 over 80. Her pulse was 70, her respirations were 17, and she's still on oxygen because she's anxious.
Okay. All right. And you said her chief complaint was just headache. What else? Did she have anything else?
Chief headache, and she's disoriented.
Okay. All right. And blurred vision, right?
Yeah.
All right. So she had severe. All right. So what I'm catching is 23-year-old female, severe headache, altered mental status, and blurred vision. You're thinking some sort of neurologic emergency. No injuries. She was laying in the bed because she was reading when this happened. Uh, you gave a vital signs of her last vital signs were 125 over 80, pulse 70, respirations 15, and regular. And you gave her oxygen for her distress. So she was a 98. Now she's a 99. And then also you gave her other supportive care, like I'm guessing you got her covered up with a blanket and all that, so she's good to go. Awesome. Well, thank you very much, and we will take her from here. You can stop by the EMS room and grab a sandwich and a Gatorade or a slushie and be on your way.
If she was complaining of a headache though, like couldn't we have gave her like something for the pain, like a medication or something?
We don't have anything, so there's nothing within our scope to give for that.
Okay.
Yep. So also, it was asked ischemic stroke or TIA because blood pressure is okay, not a hemorrhagic stroke. So no, I'm looking at a cerebral vascular event because she wasn't giving other stroke symptoms, right? So we would have she was just giving me headache, disoriented, or slight AMS because she's distressed and things like that. So I'm really leaning more towards in the severe headache. The severe headache's going to be a big one for me. Um, and so I'm looking at a vascular event. Something's going on there, possibly an aneurysm event or something like that. That's what I'm going to be thinking of. So um, with that, they're gonna do a CT on her, and then they'll actually go through and check all that out. That's what my wife does. She does that CT stuff. I call her a bone photographer. She does, it's all part of radiology. So they're gonna check that out. They're gonna find that aneurysm, and then they're gonna hook her up. And you helped her out. You got her done. All right. So awesome job. Thank you very much. All right. Let's look at some good questions here. All right, so let's do a review. All right, so a 41-year-old man presents with slow, irregular breathing, hypotension, and dilated pupils. These signs most likely indicate dysfunction of the, hold your answers, A, B, C, or D. Hold your answers. All right, let's hear them. Okay, okay, okay. All right, so remember, okay, all right, a lot of C's. So slow, irregular breathing, hypotension, dilated pupils. All right, now I'm starting to see some A's. The big one for me is the irregular breathing and the hypotension there. All right, so A is going to be the right answer. A is going to be the right answer. I saw where y'all are getting at. So the brain stem is responsible for breathing, blood pressure, pupil constriction, right? Near the rear. So the brainstem dysfunction will result in abnormal findings of those functions. That's why that brainstem, when it's trying to get shoved through that, when it's getting pushed through that magnum foramen, then or foramen magnum, then we want to. That's why all the problems with breathing and blood pressure and all that start to act up because it's getting pressure on it. So it starts to make everything all screwy. Good job. All right, so for C, the cerebrum, that's the big part, right? That's the big part of the brain. So remember, that's where emotion, thought, touch, and movement come in the cerebrum. And in the cerebellum, walking, talking, all that good, or walking and all that good stuff, more of. Left side of the cerebrum is talking for most people. All right. An acute ischemic stroke is caused by A, B, C, or D. Hold your answers. All right, go ahead and give them. Okay. Okay. All right. Right. Answer is D. Good job. Good job. Good job. Good job. All right. A 56-year-old man experienced a sudden severe headache and then became unresponsive. He has a history of high blood pressure. High blood pressure. The most likely cause of his condition is A or an A, B, C, or D. Hold your answers. Hold your answers. All right, go ahead. Give your answers. All right. All right, the answer is A. All right, so A. All right, moving on. All right, unlike an ischemic stroke, a transient ischemic attack is characterized by all of the following except A, B, C, or D. Hold your answers. Hold them. No answers. No answers. Okay, go ahead. Let's see them. Got some B's, got some B's. All right. B is the answer. That's right. Whoops, I didn't mean to do that. Something I was wanting to look at here. All right. Let's see here. A patient with a suspected stroke presents with slurred speech that is difficult for you to understand. This is referred to as, hold your answers, A, B, C, or D. Hold your answers. Try this out.
Why you a wet kitty? Um,
All right. Hold on. All right. Now I put it up. I put it up there. So go ahead and start answering it. See if you can answer it in the poll. Put a poll out there. All right. So far we got 84% say D, 15% say B. Let's see what we got here. D. I like this. I like this way. Now I just need it to where I don't have to do the same thing every time. All right. Next question. Next question is a type of seizure that is characterized by severe twitching of all the body's muscles and lasts for several minutes or longer is called a what? A, B, C, or D? You can answer anytime you want. Try the poll. Awesome. Keep on answering. Oh, Natalie, if you don't mind, use the poll up there. Right? Got a few more people to answer. Maybe not. All right, so let's click it, see what we got. So the answer is D. D. So a type of seizure that is characterized by severe twitching of all the body's muscles and lasts for several minutes or longer is considered a D, generalized seizure. There's your figurings there. Wonder if I can use poll and that this will work. Nope, it's not going to let me do that either. That stinks. All right. Ooh, this one may work better. All right. Next question. The most important reason for promptly transporting a stroke patient to the hospital is A, B, C, or D. Hold on. Don't answer. There we go. Awesome. All right, go for it. Answer it up. All right, remember time. Why is time important? Why is time important? All right, got 11 results so far, 12 results. All right, let's go ahead and rip and roar. All right, so the answer is B. Remember, for time, stroke patients, time is of the essence because if we can get there within 3 hours, we can give them fibrinolytics. 6 hours, we can do mechanical mitigation, right? So we gotta, that time is very important. All right, next question. All right, so our next question, which of the following are components of the Cincinnati Pre-Hospital Stroke Scale? A, B, C, or D? Got 7 votes. All right, 15 votes. Awesome. All right, let's rip and roar. Let's see. Answer is C. C. The 3 components of the Cincinnati Pre-Hospital Stroke Scale are facial symmetry, speech, and arm drift. Both sides of the patient's face should move symmetrically, equally when they smile. The patient's speech should be easily understandable without slurring. The patient should be able to hold both arms out in front of their body with their eyes closed and palms up without one drifting down. Awesome. C, C, C. All right. Your patient opens his eyes when you say his name and is making incomprehensible sounds and withdraws when you pinch his earlobe. What is his GCS score? Your patient opens his eyes when you say his name. He is making incomprehensible sounds and withdraws when you pinch his earlobe. What is his GCS score? Let me put it up here. Ah, it's not going to let me use it no more. All right. So what? So go ahead. Put your answers into the thing. It's not going to let me use that app anymore. I have to buy it. I actually have to get Rob to buy it. Okay. So far we got 8. So opens eyes when you say his name, making incomprehensible sounds, withdraws to pinch in the earlobe. Where's it at? There it is. There you go. Eye opening. In response to sound, so 3, okay? verbal response. So 3, 4, 5. Okay. Withdrawals from pressure, 4. So 9, right? 9. Because a pin, this this marker here has a GCS of 3, right? Because the lowest it goes is 1s across the board. So that marker has a GCS of 3 even. So keep that in your mind. All right, so looking at this, got a 9. Got to look and see which one we're on. All right, so A, right? A. All right. I'm going to close it up with that. All right. Awesome, everybody. Awesome. We've had a good night. All right. So your class code for tonight is 1986. 1986. So what happened in 1986, you asked? So the Advanced Trauma Life Support ATLS program is introduced in 1986. So it provides standardized protocols for the management of our trauma patients. So the introduction of the ATLS program, it marked a significant advancement in the standardized care of trauma patients. So ATLS, which is a great class, by the way, the guidelines provide a systematic approach, which I always preach about, right, to initial assessment, resuscitation, and the management of our trauma patients. So this program has widely been adopted worldwide and has contributed to the improved outcomes for critically injured individuals. ATLS, fantastic class. You ever get a chance to take it, jump on it. ATLS, AMLS, all of those awesome classes. All right, so that happened in 1986, which is your class code. Don't forget to do your attendance form. Saturday, August 19th, 2023 at 11:59, the test for Chapter 17, Cardiovascular Emergencies, and the test for tonight's class, Neurologic Emergencies, is going to close out, right? So we want to make sure that we take Chapter 17 and 18 before Saturday at 11:59 p.m. All right? So I'm going to send that out as soon as I get done here. I'll send that out tonight. The discussion, and it's going to be due. It's going to be due at the end after the module test. It'll be due after the module test. So we got a couple weeks. All right, so or a little bit. We got a little ways. Coming up next are Chapter 19. Chapter 19 is going to be up next. That'll be on Tuesday. We'll be talking about gastrointestinal and urologic emergencies. Gastrointestinal. Yes, there will be another discussion question. Those discussion questions help you out with points. So at the end of the modules, I try to put those in there, and I put them in the grade books to bring up the point values and to give it's like bonus points. Give you some bonus points in there. Okay. So Tuesday, Chapter 19. I'll put the discussion question up tonight so that we can get them all answered in. All right. Other than that, does anybody have any questions about this chapter tonight? About Chapter 18, Neurologic Emergencies? Does anybody have any questions? All right. If not, then don't forget, class code tonight is 1986. Don't forget to do your attendance form, and don't forget Saturday, Chapter 17 and Chapter 18 test or quizzes are due. The tests are due. All right. Other than that, I'm going to go ahead and quit recording. If you don't need me after I quit recording, y'all can go ahead and get on off. I appreciate y'all very much. Thanks for coming out.